That's good. And there's our notification that it's official. Um, so it's a wonderful pleasure to have the opportunity to introduce our lovely colleague, Dr. Ali Mendelson. Dr. Mendelson did her undergraduate at Boston University and her medical school at Weill Cornell, her intern year at New York University, and her neurology training at University of Pennsylvania. And then she went on to do her hospice and palliative medicine fellowship at UC San Diego, where she obtained a grant from the ACGME to do some of the work that I think she'll be talking about today. I should mention that it was a very generous and wonderful donation from a family that really recognized the need for specialist neurology palliative care that enabled us to bring Dr. Mendelson onto our group. So we're really thrilled and very lucky to have her with us. And I hope a lot of you are getting to know her since she's joined us, and I hope more of you will get to know her here. I would mention, in addition to the background she has, there's also some narrative medicine pieces that I hope she doesn't mind me mentioning that she published in the Neurology and Humanities section of Neurology, as well as A Piece of My Mind in JAMA. So I'll be very curious to hear her talk today, and I hope more of you will get to know her and her work that I think can benefit a lot of us.
All right, I think we're going to jump in. Thank you, Dr. Graver. I am really honored to be here and presenting the talk. It's titled Capturing Dignity. I'm going to be talking about some research I've done over the years looking at the use of photographs to bring dignity to patients and help clinicians recognize the meaning in their work. So I have no disclosures. So I'm going to start today. I'm going to first give you a little bit of background on what dignity therapy is and define dignity conserving therapy. And I'm going to spend most of my time talking about the research I've done looking at the use of photographs in place of a written narrative as a novel tool to improve dignity. And we'll talk about the impact of this intervention on patients and families as well as providers. I'm going to try to focus a little bit on the benefits for patients with neurological disorders, in part because it's relevant for the audience today, and in part because the patients who are enrolled in our initial feasibility trial were all admitted to an inpatient neurology unit. So I thought I'd give just a brief minute about me because, as Dr. Graver said, I'm new to UW and really honored to be here. I'm from the East Coast originally and then moved to the West Coast to do my fellowship in palliative care, and now live in Seattle with my husband, Fima, who's a cardiology fellow here at UW. And the reason I put this up is that he had given me a piece of advice when I first started training, which was to pick one thing outside of medicine to focus on. And I picked photography. And that's looked different over the years, from starting a wedding photography business as a resident to now just shooting film photography for fun. But it's really shaped the way that I see the world and think about how people want to be seen and captured. And it's, I think, led to the work that I'm going to talk about today, but it's also helped it evolve over the years. So I'm going to start with a quote. While we're often successful at treating physical symptoms associated with advanced disease, we're often less successful at treating emotional suffering and loss of dignity. And this work all started actually back in New York City. I was a third-year medical student rotating through the ICU, and an elderly gentleman was admitted, and our team knew strikingly little about him. We knew his initial chief complaint. The assumption was that he had come from a nursing home and he would be discharged to a nursing home, but he was kind of a grumpy older man and people tended to avoid his room. But I, being a third-year medical student with little to offer besides data collection and talking to patients, spent some time with him one afternoon and learned that he wasn't grumpy, he was grieving. His wife had died shortly before his admission, and he hadn't come from a nursing home. He had been living independently, taking ballet classes almost daily up until the time of admission, and he had been in multiple Broadway shows, had met his wife backstage at one of those shows. She was a professional dancer, and he entertained me for hours with stories of these New York City dance legends. And I couldn't help but be struck by how sad it was that we didn't know any of this about him, and that the snapshot that we got when we walked in the room, and this isn't the actual patient, but essentially what he looked like and what the room looked like. And the snapshot told us very little about who he was. We didn't know where he was from, what was important to him, what his goals were. And I think that really affected the care that he got. I couldn't help but wonder if instead of walking in the room and just seeing this, we saw this. And I wonder if we would have treated him differently and if the outcome would have been different. So as a fourth year medical student, I got some funding from the geriatrics department to study this. Unfortunately, as I think many of you probably know, IRBs can take a long time, and we didn't get IRB approval until close to graduation. So we only had a few patients enrolled, but two stood out, and I don't have their photos, but I just wanted to mention their stories. One was a woman who was admitted for cancer pain, and her perception was that the nurses all hated her. She was always asking for medicine. She was yelling. She was really uncomfortable. And the picture that she chose was a picture of her decked out in St. Patty's Day garb and cheering with a beer. And when I asked her why she chose that photograph, she said, because I wanted the nurses to know that I'm fun. This isn't me. I don't want to be this person in the bed. This is me on the wall. And it was really important for her to be able to portray that. The second patient was another older gentleman who, when you walked in the room, you would see him lying on the bed, wearing a diaper. He was nonverbal. But then his wife chose this photograph of him on his wedding day, wearing his military outfit. And it was really meaningful for her that we could see her husband the way that she knew him, and the way that she saw him. Around the time that I was applying for residency, somebody, after hearing about this work, had asked me if I'd heard of dignity therapy, which I hadn't at the time, but that started kind of a deeper dive into the research on dignity and dignity therapy. And I started by asking just what is dignity? And I found there are variable definitions, whether it's making patients feel like they're still of value, a state of the soul, the sensible things like keeping them clean, keeping them comfortable, or as the definition says, the quality or state of being worthy, honored, or esteemed. I also learned that the definition is complex. It varies from individual to individual, and it serves as the basis for a field of research, including a therapeutic intervention called dignity therapy. And dignity therapy is a form of psychotherapy that utilizes narrative really to improve quality of life and the sense of dignity among patients at the end of life. I think one of the key lines is the word narrative. I also learned that few patients actually have access to dignity therapy, but anyone can provide dignified care and ask the patient dignity question, which is a validated question that I actually ask all of my patients now on my first time meeting them. And that's simply, what do I need to know about you as a person to give you the best care possible? I learned that prior research has found that healthcare providers can influence the dignity of patients, and that can actually improve patient experience, satisfaction, it can improve outcomes. Good communication is an essential ingredient for high quality and safe care. And better interactions between providers and patients not only benefits patients, but it can also result in improved job satisfaction for those who work in healthcare. And for those of you who were able to watch Dr. McGranahan's talk a few weeks ago, you know the importance of recognizing, preventing, and managing burnout in healthcare. I wanted to read another quote, and this is a bit long, so I apologize, but I think it's worth taking the minute. There is an intimate connection between every person's self-image and the way they feel they are seen by the people working in the healthcare system. Whether they realize it or not, and whether they desire it or not, patients and families look to them as they would to a mirror, seeking a positive reflection of themselves. Attitudes and behaviors can shape those all-important reflections. It's important to reflect back in appreciation of the whole person and not just the illness or affliction. No one wants to feel invisible, and no one wants to be seen as a tumor or a defective part. Patients want to be seen as people who are seeking help with a medical concern. And as the founder of Dignity Therapy said, dignity therapy comprises not only what one does to patients, but how one sees patients. Yet, picture your morning rounds. You're walking from room to room. All of the patients are lying in identical hospital beds, often wearing identical hospital gowns. Their hair isn't done. They're not wearing the makeup and clothing that they would typically put on the morning before leaving the house. And like the first patient I talked about, this snapshot you get of the patients tells you very little about who they are, what's important to them, what their goals are. And too often we don't ask, if nothing else, because we're really busy. But now imagine if you asked all of your patients to choose one photograph that represents who they are and how they want to be seen. So we did just that. As a neurology resident, I conducted the initial study looking at the use of a photograph in place of a written narrative as a novel tool to improve dignity. And this was really, in thinking about dignity therapy, that was utilizing narrative. And often that was for the patient's benefit, not for provider benefit. There's other literature looking at use of narrative to capture patient stories. There's a bunch of that work is being done in the VA system. But I found that that requires somebody to actually go to the chart and read the narrative. Similarly, there are lots of patients who hang photographs on the wall, but I found that most of the time those photographs would be on the wall facing the patient, and then our team would walk in and our backs would be to them. And sometimes we'd notice them, but wouldn't stand there and look at them all and ask questions. So I wanted to find a way to simplify that and really engage more providers. So this was really just a feasibility study. My goal was, do patients want to participate? Do they want a photograph on the wall? If they put a photograph on the wall, do providers actually notice them? And if they notice them, do they ask questions about them? And then do patients feel as if that photograph and those interactions improve their care? I was also curious what it is that patients actually want providers to know. What are they proud of? What are their goals? And how does that relate to the photograph they chose? So we recruited patients over the age of 50 who are admitted to an inpatient neurology service at Penn. Patients or their surrogates chose a single photograph, and we hung an 8x10 photograph right above the head of the bed. And again, this was because I wanted it to be in a place that was really easily visible and you couldn't miss it. I returned and did structured interviews with the patients about 24 hours after the photos were hung. And then we recorded and transcribed the surveys and reviewed them by theme. So again, this is a small study because these were pretty time-consuming surveys, and it was just me as a resident on service for most of this. But we recruited 11 patients and families, and they all agreed to participate. 7 ended up completing the survey. Others either were discharged or moved to different units. You'll see that a little more than half were male. Most are on the stroke service, with about a little less than a third on the neurology ward service. And most of the photographs, or at least a little more than half, were chosen by family. And that was in part thinking about patients who were admitted with a stroke. Some of them had difficulty communicating and couldn't choose the photograph themselves. So I included this in case anybody wants to see what questions we asked patients. And I'm not going to read them all, but you'll see that they're divided into a few different parts. The first is really asking why that photograph. What is it that you want? What does the photograph mean? What did you want to tell with the photograph? The second part is really asking patients, what did the photograph do? Did people notice it? Did it affect your interactions with providers? The third part saying, and then separate from the photo, what are you proud of? What are your goals? What do you want providers to know? And then the last question was one I'd asked all my patients as an intern and just wanted to expand on a little, which was simply, if you could give one piece of advice to young doctors, what would it be? So this is the only slide with numbers, actually, and then I'm going to jump into some of the photos and quotes from some of the surveys, because I think that's where the heart of the data really lies. But here you'll see that most patients, 86%, said the providers noticed the photograph, and most felt like the photograph changed their experience in the hospital. I was initially surprised by how low this third number is on the bottom, where it asked, did the picture help your providers learn more about you? But when I went back to the actual surveys and listened to the recordings, the people who said no or maybe really to these last 2 questions would often expand and say, I don't think they could have learned more about me because they already knew everything, or I don't think the care I got could have been any better. But being on some of the teams and being on rounds where people were asking about the photographs, I wonder a little bit if it would have been different if the photos hadn't been on the wall, or if we had some pre-post intervention data or some randomized data. So I question that third number a little bit. Some of the themes that came up, the most common one was family. People also talked a lot about their personal characteristics, kind of who they are, the things that you can't see when you just look at them from the outside. A lot of talk about being hopeful, being goal-directed. People were thinking about the future, and they wanted their providers to know that they had hopes and goals that they wanted to reach. And physical appearance was a really common reason for why patients chose a specific photograph. They wanted to look good. And this is, I think, the most fun part. So this is, I'll call him Mr. W, and he was admitted to the Neurology Stroke Service. And when I asked him why he chose this photograph, he said, "I think it brings an association as to who the heck is laying in the bed. See what you can do to get me looking like that again. And Dr. Alley's doing a study, so you have to sit down and get to know me." And this photograph, I think, actually really improved his care and changed the outcome of his care, because looking just at his age, people are questioning whether or not he would be able to tolerate more aggressive treatment. He had both cancer and a stroke, but he was really adamant that he was young at heart. He lived alone. He was really functional. And in the end, he did really well and also felt really a lot of pride in having this photo on the wall. Most people chose a photo from this phone, but he had his family drive 2 hours home to get this picture off of his mantle because it meant so much to him. This is, I'll call him Ed, and he was admitted to our neurology ward service. And he was really struck by the fact that walking in the room, you wouldn't know if he slept under a bridge or lived in a penthouse. And he had been a businessman his whole life, so his suit was a really big part of his identity, and he really loved having this photograph on the wall. And when he said, in here it's really impersonal. I mean, I'm 428A, but up there, I'm Ed. This gentleman said, "They focused on me, not the picture, especially the neuro team. Everyone was good, but your team was the best. They really focused on me, especially the head doctor, Dr. Rubenstein. I liked the way he talked to me like a person." And I included this quote because he was one of the patients who didn't think the picture made a huge impact in his interactions with his providers or the care he received. But I was on service when we were caring for this gentleman, and the team spent a lot of time talking to him about the photos and about his family. And I wonder a little bit if it would have been different without it up on the wall. This woman chose this photograph simply because she looked good in it. She was so proud to have a photo on the wall of her son's wedding with her makeup on, the way that she would normally look when she left the house. And when she came back in to see me in clinic after discharge, she waltzed into the clinic room and proudly announced, "See, now I look like my photograph." And when she was readmitted a few months later, I wasn't on service at the time, but I got a call from the team saying she's back and she really wants her photograph on the wall. So we reprinted that and hung it up for her. This woman's daughters chose her photograph, and they had trouble choosing between two. She had been a midwife before moving to the US, and they really wanted the healthcare team to know that she was one of us. But they ended up choosing this photograph because it showed the brightness of the mother that they knew. Not the blind one, but the lively one. And this was one of my favorite surveys. This gentleman was admitted to our neurology service and pretty quickly transitioned to comfort care. I had consented him into the study and we had hung the photo on the wall, but I wasn't going to return to survey the family. It didn't seem like the right time, but they found me in the hall and were disappointed. They'd been really excited to participate. So we went into one of the family rooms and turned the recorder on and talked probably for an hour. And I wanted to redo some of their quotes. "It's very comforting to see how he looks. It's sometimes hard to get the image of him lying there dying out of our heads. It made it not as cold. Made it, I guess it humanized him and made him look like a human, not just a patient. Everyone that came in was looking at the picture and knew what he was. That's what he looked like 2 weeks ago even. I also envisioned that picture following us through the next difficult weeks of service and burial. And that picture is not just an ordinary picture anymore of Dad. That's going to be the iconic picture of Dad now, I think. You're not just a patient here, you're family." This is the last photo that I'm going to show from this initial study. This gentleman was a pretty young gentleman, I think in his 30s, who was admitted with a stroke. And he was discharged before he could complete the survey, which he was disappointed in. But I wanted to include his photo and his story because he had kept telling the stroke team that he really needed to get back to playing hockey. And I don't think the team was really hearing him. And then we hung this professional photo up of him as a hockey goalie. And I was standing in the hall one day and the stroke attending who was on service at the time came and found me and said, "Gosh, did you see that photo? We really have to get him back to playing hockey." And it was meaningful because that was the exact goal of the study, was for the photo to really impact the care that patients get and impact the way that we see them. So in conclusion, this was, again, the initial qualitative study looking at the use of photographs in place of written narratives as a novel tool to improve dignity. And I found that patients are interested in displaying photographs and providers notice them and they ask questions about them. The challenges were that this was obviously a small sample size. We didn't have pre-intervention data. This wasn't a randomized trial. Thinking about the themes, family was the most common theme, but I suspect that was related to the number of families who chose the photograph and completed the survey. And availability of photographs was a challenge because these were patients who were admitted to the hospital. So they were mostly limited to a photograph that either they or their family had on their phone, with the exception of the first one I showed where he made his family drive a couple hours to get his favorite photo. And then, as Dr. Graber mentioned, as a fellow in San Diego, I received a grant from the ACGME to continue this work. And we have an ongoing nurse-led standard project going on at UCC. It's a nurse-led standard of practice in 4 units. There's a med-surg unit, an oncology and inpatient palliative care unit, and 2 ICUs. And the goal is for all patients admitted to these units have the opportunity to hang a photograph above their bed. And we were hoping to investigate the effects again on patients and surrogate sense of dignity, with the eventual goal of expanding the definition of and access to dignity conserving therapy by comparing the themes that came up in the survey asking about the photograph with their responses to that patient dignity question that I mentioned earlier. I also wanted to, in this study, which is different than the feasibility trial, really look at the effects on providers and evaluate this new standard of practice on clinicians' sense of meaningful work and feelings of burnout. And I wanted to briefly mention the Back to Bedside program because I think it's a great opportunity if any of you have residents or fellows who are interested in similar work. And this was designed to fund projects by residents and fellows for residents and fellows to decrease burnout and help trainees recognize the meaning in what they do. And initially they were planning on funding 5 projects our year. We were the first class to go through, and they had so much interest that they ended up funding 30. And I think the second class is going on currently, and it's a really great opportunity because you get to meet in Chicago a few times, and there's great education on actually conducting this sort of research. And a great community. So I recommend that if anybody is interested. So the study at UCSD is still ongoing. I'm going to show you some of the data that we have from the pre-intervention survey and some of the more patient photos and quotes, and then a little bit from the post-intervention survey because some of the provider quotes I think are pretty striking. You'll see here, this is a survey of 172, mostly nurses and physicians who work on the units that we included in the study. And you'll see that burnout rates are pretty high. The majority of providers are feeling burned out at least a few times a month, if not significantly more. You'll also see here when we asked if they've become more callous towards people since starting the job. While many people say it's rare, these are people who are working daily with one-on-one with patients, providing direct patient care, and not an insignificant number are feeling callous towards the people that they're working with or treating. And then there's the question asked, I found a meaningful career. And when you first look at this, it looks like the majority of people say absolutely. But looking at the numbers at the bottom, it's only 60-something%. And again, these are people providing direct patient care every day. And we might all have good and bad days, but I thought more people would say, even if I have a bad day, the work I'm doing is meaningful. I have confidence in that. And there are people who actually really don't believe that at all. And I was struck by these responses. So I'm going to go through a few more patient quotes because again, I think this is kind of where the best part of the data lies. This woman said, and I couldn't include this photo because it included a couple family members that hadn't consented, but she said, oh yes, absolutely, absolutely, when we asked if this photo improved the care that she got. She said, I can sit here by myself and I'm just another patient in another room. And not that the nurses and doctors aren't incredible, but they walk in and I almost see a smile on their face when they walk in and see the pictures and we start talking about it. And there's that connection that we get right there. And it's been incredible. This woman said, I've gotten many comments on it. I've had nurses and even the doctors comment and ask about the photographs, where they were taken, what my dog's name is. And I feel they're getting to know me a little bit better rather than just my illness. It shows a part of me and a part of my life that other people wouldn't normally see if it wasn't up there. The photographs have just been, like I said, a connection to the people who come in and talk to me in a way that they would not have otherwise. There's simply been a lot of interest, and I can have conversations with people that don't have anything to do with me being sick. They look at that, and they look at him, and they see what they have to get him to. There has been something in common with every single person, and that brings almost a bond and a closeness. I think it really kind of connects us. And I apologize that this young gentleman's face is blacked out, but we only included patients' faces because they were the ones who consented. This I'm going to try to play for you if you can hear it.
Does having this photograph posted on your wall improve your sense of dignity?
Yeah, I think so, because I don't think when, like I say, the custodians or the nurses or even the doctors come in and they see me sitting here in a gown with the oxygen and everything on me and all the wires and stuff, they look up at the picture, they know there's another side of me. You know, there's a normal side of me. So I think it really helps. It helps them understand me, and through that, they're more comfortable talking to me, which in turn makes me more comfortable with interacting with the doctor. So.
Those are my questions.
Oh,
do you have
okay.
Anything to add?
No, not really. I really think that's a really good idea, though, whoever came up with that idea, because I think it really humanizes the patients. You know, I know the nurses and the doctors see people in all kinds of conditions, and it's hard to picture them normal, in a normal life, in a normal setting. And the pictures that people submit, I think it helps see them in another light. And it makes things more comfortable.
So I wanted to read some of the provider responses because, again, we hadn't surveyed providers when I did that initial feasibility trial, and the post-intervention surveys are still kind of rolling in San Diego, but I've been really struck by some of what people are writing and think they're worth reading. Seeing a picture of the patient outside of the hospital setting helps give clinicians a glimpse into who they are as a person. It refocuses the clinician's mind to the fact that we are caring for someone's mother, father, wife, brother, sister, aunt, uncle, friend. All in all, we are caring for a human. Seeing a picture of them helps humanize them. They always look their happiest state in the picture. Sometimes we don't even see people on the bed. Sometimes we just see the cancer, pain, vomit, etc. It's all tasks that we need to do. The picture is very personal and connects and encourages conversation. I feel like I'm making a difference in a life, not just another statistic. It was a helpful reminder that the goal is not necessarily to cure everyone, but to try to get them to a point where they can return to a more normal life so they can enjoy their time. I came into this profession to be able to help more people. It can be very fatiguing work and very tempting to lose empathy. It helps to see these photos and remember why I got into this profession and have compassion. It helps to remind me that a patient has been much, much, much more than the illness that is ravaging their body now. I feel as though the photographs gave meaning to the patient, and I was able to see the patient for who they are. Our cases in the ICU are sometimes very difficult, and it's hard not to feel burned out by them. But with the photos, it helps me be a more compassionate care. I had more empathy when I would get frustrated that someone was intubated for too long and care wasn't withdrawn. It helped remind me that there was someone's mom, sister, daughter, or friend behind all the tubes and wires. Increases compassion. You treat a disease, you win, you lose. You treat a person, I guarantee you'll win no matter what the outcome. So far I've talked about kind of the initial feasibility trial and some of the work that's ongoing at UCSD, which has really took that feasibility trial and kind of put it in action. And we're looking at the effects on patients, but also on providers. But I think there's been challenges and things that I am excited to continue to work on. In my current practice, I actually ask all of my patients to bring a photograph in that represents how they want to be seen by their providers. It's been part of my practice just as a palliative care doc. I did it while working in Portland before moving here, and I've been doing it in the Alfred Brain Tumor Center. And I found it's especially important in the Brain Tumor Center because the patients that we're meeting typically present to the emergency room with an acute neurological change. They have surgery, they might be started on steroids, their hair is shaved, they have a scar. By the time that they're seen in our clinic, they don't look like themselves. They might not feel like themselves. They may not be communicating like themselves. And we never get to see them the way that they were, the way that they presented themselves to the world before this big event. So we've applied for the Patients Are First Innovation Pilot to try to support and study the impact of this intervention. And again, look at the effects both for patients and families, but also on providers. I think we all know, and as Dr. McGranahan talked a lot about, rate of burnout is really high and can really affect both sustainability for our own careers and the care that we're giving to our patients. Right now, I've been having patients send me the photos by eCare, and if possible, I paste them into my notes, but sometimes just talk about them with the patients, and the communication and the conversation that we have about the photos can be really powerful. But my long-term goal would be to really try to integrate this into the medical record, into the way that we provide care beyond just for the patients that I am seeing. And I think my long-term goal would be that patients can upload a photograph, almost like a social media photo. For those who have Facebook or Twitter or LinkedIn, you have a photo up there and you can pick what you want and you can change it when you want. And I think it would be really neat if in the patient portal in eCare, patients can log on and upload a photo and change the photo over time, because we started asking patients what it is that they actually want to tell with the photo, what they want to say with it. But that's just at one point in their life and at one point in their illness. And I don't know if that would change as their disease changes, as they get older, as their life changes. And that would give them the opportunity to change it over time. And then my other long-term goal would be that if patients have the opportunity to choose these photographs as an outpatient and they're uploaded to the chart, if they're admitted, it would be great to have the ability to just print those photographs and hang them above the bed. Because what I found in that initial feasibility trial, again, a lot of the patients were admitted to the stroke service. They might not be able to communicate on admission. They don't get to choose the photograph for themselves. They're relying on family to choose the photograph for them. And what I don't know is, do patients and families choose the same photograph? I suspect not. And that is another potentially interesting study too, is do patients, medical decision makers choose the same photo? Do they see people the same way that patients are seeing themselves? But if patients get to choose their own photograph and when they're admitted, it's automatically hung above the bed, even if they're unable to communicate, that kind of gives them the power to speak for themselves and share who they are with their providers and care team, which I think is empowering, could really improve their sense of dignity, but I also think really improves our own sense of meaningful work. Walking home from the hospital as a resident, I think we all know those days can be long and tiring. And sometimes you can just, all you feel is annoyance at your pager and at your to-do list, which can feel never ending. But on the days where I spend an hour talking to patients, looking at their photographs, doing these surveys, I would go home thinking about that and thinking about how lucky I was to get to meet these people who are pretty amazing, and how lucky I am to actually get to do what I do every day. And I think that's in and of itself is really important. So I wanted to leave you and actually want to give everybody a few minutes. This is a little bit hard by Zoom. I think it's a little bit easier to do in a live talk. But I wanted to give everybody just a few minutes to look at their phone. You're all sitting at a phone or computer. I guess that's the one power of Zoom, is everybody probably has some photos available. And just think about what photograph you would choose that represents who you are and how you want to be seen, and what would it be? And if anybody wants to share, we have some time. And I think that it can lead to some neat talking points. So I'm going to give everybody just a minute or two to think about this.
Do you want to tell us? Do you want to tell us why you chose that one?
Sorry, do you want me to tell about my photo? This was from our wedding, and I think this for me is just joy. It was this really happy day, and we're surrounded by all of these people that we love and that are meaningful. And I can't imagine, this is everything that I love about life outside of the hospital. It's family and friends and joy and celebration and flowers and nature and home. So for me, this, if I was in the hospital, this is what I would want, both for myself to look at, because I think it would bring me joy, and I think how I want to be seen. And I don't know if anybody wants to share. I don't know if you could share your photograph, but you could try to share your photograph, and you could certainly tell us kind of why you chose a specific photograph, or kind of what you're thinking about and what you'd want to share. It's okay if nobody wants to. This is a kind of hard format to participate.
I could, this is Evan Luxembourg. I'm one of the neuro residents. I don't know how to, here, I'll turn my video on. I'm on my phone, so I don't know how to exactly share it, but, and it's not quite a photo, but like a screenshot from a video that was taken of me doing stand-up comedy. And that was like, it's the one time I've ever done it, but it was like a pretty important thing for me. And I'd probably choose that at this point, because I'm not married yet. That probably would be a solid one. But at this point, it would be kind of like me, an interest of mine outside of medicine, but also me kind of getting over like fears of doing something like that. And it was a very, very fun experience. So I'd probably want that if I were a patient right now.
Neat. Thanks, Evan. So I'll give everybody another 30 seconds or so, if not.
So when I look through my phone, I don't see pictures of myself, but of my family. And that's actually what I would want people to see. I don't, that's I think what I'd be about is the people around me and not myself.
And that was the most common thing that people were choosing. And I think patients wanted to be able to say, these are the people who are important to me. And I thought it was, when the families are choosing the pictures, I think often what came up in the surveys was families wanted the docs to know and the nurses to know and providers to know that this person's important to somebody. This is not an individual lying in the bed. This is somebody who means a lot to the people in their life. And this is an important person. And that was a really common reason for why people chose a specific photo.
Allie, this is Annie. I have one that I'd be happy to try to share, but then I think you have to unshare your screen if you want me to. Yeah. So can you guys see that?
Mm-hmm.
So this is kind of like what Claire said, that I was flipping through. I mean, I don't know if this is like the one I would choose if I spent a long time, but I was flipping through my photos, and of course it came to mind that it would be like at top of a mountain somewhere. That is my 13-year-old dog and my husband. And that's where I feel like the most like myself. And I think that's what I'd want patients to see.
I love that. Thanks, Annie. That was it. I want to leave some room for questions because I think I love this topic and I love to hear what people think, especially as we're starting to think about how to expand this and build on it. So I'm going to leave it there and just open it up.
Can I say something? Hi, everyone. I'm Allie's friend from Fellowship, listening from Santa Rosa, California. I was just thinking about how the photos, it seems like there's a theme of people using them to try to tell the medical team, get me back to this, you know, sort of like, this is my goals of care, you know. I don't know, I just never thought of it that way before. I've heard some of these talks from Allie before, but I sort of thought of it in a different way today.
And I think that's the fun part about using it in a palliative care clinic is meeting somebody for the first time and really getting a sense of who they are, what's important to them, and what their goals are. I think the photo really gives you a snapshot of that, or at least leads to a conversation that tells you more.
Hi, Allie. This is Mike Williams. I don't know if we've met yet. I'm over here at Harborview, and one of the groups of patients that I take care of are young adults who are coming over from Seattle Children's Hospital into the adult healthcare system for the first time. They get too old, and my particular area of interest is hydrocephalus. And one of the things that has emerged from the literature on the transition population, which is what they're called, is that it's important to really get to know them and help them to get used to the adult healthcare system. And for almost all of them, the first 10 or 15 minutes of my visit is to just get them to tell me who they are and what they like to do, and not quite having a picture of them, but oftentimes their parents will bring them out. And it's that same thing, so that they don't feel like they're just another shunt or somebody with hydrocephalus, but that we're interested in caring for them and, you know, setting on our sights on helping them to get through the next 40 years of their lives with this disorder that they've often had since infancy. Mm-hmm. So I think, you know, we can do as much by asking those open-ended questions, and there's just a wonderful benefit from having the photos as you've shown us.
Mm-hmm. I think I'm a visual person, so I like the supplement of the photo with their story. I think it also helps me remember people and really see them differently, because I think we meet so many patients, and I think it can be really hard to remember who really makes them, even if you write a long note and try to capture it in writing. And I think when I look back at my note and see the photo, I think it really immediately helps me recall who this person is beyond just their disease and where they are in their disease course.
Well, I'll ask the question. What about similar photos for the providers? You know, when docs walk in the room with the white coat with 4 or 5 people, you know, entering the room, and they have the ID on, you know, you don't get a sense who that person is. And in the situation that you're discussing, particularly in the, you know, the end of life care, you know, I can see that being of some value also.
And actually some of the projects from the other teams who are doing the Back to Bedside program were doing just that. One of the coolest things were these almost baseball cards that teams were making and handing out with all of the providers' photos and fun facts about them. And the patients would essentially collect the cards, and they really got to know their team. And it also led to conversation, but more from the provider end. And that was another really neat way to go about it. So some of that is in the literature too, and still coming out, because some of the work is still being published from it. I agree completely. I think you could do this both ways, especially now with everybody wearing masks. I feel like I've been using photos even more in clinic because there are patients that I never actually see. So I've been doing some initial visits, and some of the patients I've even asked to do the second visit by Zoom purely so we can see each other's faces. So I think this is helpful because at least it gives me a sense of what they look like.
It's interesting. I was reflecting, I'm one of the pediatric neurologists, and I make a real effort when I'm seeing patients in clinic to try to get to know, you know, that kid's hobbies and what they want to be someday and all these facts about them. And it occurs to me, in most cases, I don't even know their parents' names. I just call them mom and dad. And, you know, really when we're taking care of kids in a very real way, we're treating the whole family. And I know so little about their parents most of the time, even though I tend to know some stuff about the kids. And it makes me wonder about, you know, trying to expand that fleshing out of this person from just the patient in that setting to the family members too, which I wonder on the adult side, like especially with dementia patients or patients that have real need for caretakers that are going to be ever present at appointments, to what extent does that bleed into this kind of concept too?
Yeah, sorry. This is Marie Davis. I see a lot of Huntington's as well as Parkinson's patients, and yeah, I just want to comment that is yeah, the whole family involvement and getting to know the whole family and how that patient, you know, used to be when they were more functional has been, and I've had families bring in like a CD, the patient when they used to be, you know, a lot more functional, and that's been really helpful. But yeah, to make that more of a routine thing would be nice.
Allie, this is Annie. I wanted to say, you know, there's been so much great conversation about how many patients see this as a tool to help people understand where they would like to get back to. But the thing that my mind immediately went towards is how do we use this our patients in general, and a lot of the pediatric neurology population, we talk a lot about seeing kids where we see them, and even those of us that work with these kids all the time, when we make assumptions about what their quality of life is, we often get it quite wrong. We often look at kids with severe disabilities and think that their limitations and their experience of their life is less rich than it truly is. And I wonder about if that 8-year-old, if I let him pick out a picture for himself, what would that teach me about the way that he sees himself and the way that he sees his world? And would that, even though his function, let's say, is the same, even though he's a wheelchair-bound kid or he's nonverbal, or would that teach me more about his joys, his experience of life, and help me see him as more of a human and less of his disability? It's a thing that has come to me while you're talking about this, that I think there's so much great potential for making those connections with our patients and understanding them better, even when it's not end-of-life care.
And Annie was with me in the ALS clinic recently, and I think this would be great for there too, because a lot of those patients are also have significant disability and they're just different than who they were for their whole life, and giving the opportunity to really show who they are in a multidisciplinary clinic to the whole team could be powerful.
Ellie, did any patient say to you, I don't want to see my, like, you know, how seeing ourselves when we looked young. Because I don't really need to see myself when I was younger, because I'm no longer
And then there was one patient who chose his favorite piece of art. So people can choose a photo of their favorite place or piece of art, because that still leads to conversation. It stimulates conversation, it stimulates connection. So I think I try to be clear that doesn't have to be a picture of them. It can just be a picture that is meaningful, that represents how they want to be seen. And it's variable. And I think that gives people the ability to not choose a photo of themselves if they don't want it.
This is Jerome. I love that you kind of looked at this in both directions, looking at how it affected both patients and providers' attitudes, and it just kind of reminded me it's been really kind of fascinating, and I've really enjoyed doing televisits lately, because I feel in a way that I get a slightly similar thing seeing patients in their own homes. And it kind of made me realize a little bit more too that even when patients come to clinic, sometimes how they choose to dress, which on inpatient side you usually don't get a glimpse of, although sometimes you do. That patients, some of them really do make an effort to show themselves to us, and sometimes it's not even maybe a conscious or intentional thing. So I love that you kind of looked at it both ways. And I think one of the things that I thought of when you were talking about how this project affected provider attitudes about burnout is, patients burn out too on the medical care system. And I wonder how often it is because they just feel like a product and that they're not seen and appreciated as a person. And I think in neurology, not following up for intended care is a significant issue and a waste issue, and sometimes really affects outcomes. So I wonder if anyone's really looked at whether this kind of intervention might improve patient follow-up. Especially, kind of as neurologists, I think sometimes patients feel like, well, I'm not getting better, so what's the point? So, I mean, that's one thing that kind of came to my mind while you were talking about this, and I don't know if anyone's really ever looked at it in a formal way that you know of.
No, I don't, but it's a definitely interesting question. I think there's so much that we could look at, like in studying the impact of this. My initial idea was just, do patients even want it? And then what do they want to even tell their providers? And now that I think I'm starting to glean a sense of that, I think the next step is really thinking about how does this actually impact care over time? I stopped screen sharing because somebody had wanted to share a photo. So if you're still interested, you can now.
Yes, this is me, but somehow I'm having trouble sharing my screen with you guys. Remind me how I share my screen again?
At the bottom, there's a share screen.
Oh, yes. So I just shared my screen. And can you guys see this picture?
When you click share screen, it should give you options, and you should be able to click on the photo, and then it should pop up.
I clicked on the photo. Can everybody see?
No.
You cannot.
You have to click OK or something at the bottom as well after you click on the picture.
I thought I did that. Let's see. Because I shared my... Can you now see?
Mm-hmm.
This picture was taken in 1964. A patient of mine lives in West Seattle. He has Parkinson's. I've known him for many years, and he brought this picture to me. He gave it.
And you were saying this was from Iran?
Mm-hmm. Yeah, this picture, he was traveling in Iran the year I was born. And he wants to go back. Obviously, he can't go back right now. But so sometimes the photo doesn't have to be from the patient.
Exactly.
I mean, from the patient, but not of the patient.
Yeah, I think the photo can be, it's so variable what people want to choose and portray. And I think the biggest part, sometimes it's really about, this is who I am, this is what I look like, or this is my goal. And sometimes it's really just stimulating a connection with the providers. And you're realizing that you have more in common than you thought. I wanted to ask, somebody had written a question about.
Maybe I'll stop sharing.
Yes.
So somebody else can share if you want. Thank you,
Yeah.
Ellie.
Yes, of course. Somebody had asked about narrative medicine in the chart at the VA, and I mentioned that briefly earlier. And I think that work is really neat, some of the VA narrative medicines. But I think the reason I was interested in this, and partly because I liked the visual, but I also found that by putting a narrative in the chart, you are relying on people taking the time to read it. And we all know how busy we are, and even an extra 5 minutes per patient can really add a lot to a day. And I'm not sure that that would be sustainable for everybody. And what I liked about the photo is it's kind of hard to miss. You don't have to take the time. If it's right above the patient's head, you see it. Or if it's right in the patient's chart, you would see it. And without asking providers to put in extra work, which I think is important also in reducing burnout. I think the more clicks and the more things we have to do and look at just adds to the risk of burnout. So I was trying to simplify it, but also give patients some control over how they're seen. Yeah, Annie just commented exactly that.
This is Jim with
Hey, Jim.
Palliative Care. Hey, thanks for a great talk. Really enjoyed this. In the ICUs at Montlake, they do what they call like a get to know me poster, and they put in a lot of photographs and a lot of content. I wonder if you have an opinion on sort of the singularity of one photo versus a collage, and sort of the sort of distraction or the focus that comes with that, and if that had sort of weighed into any of this work at any point.
I think similar to having a narrative in the chart, I think when you're rounding, for example, when I did this in residency, we had a busy stroke service and you're going from room to room. And I think it's hard when there's something above the bed that's busy with a lot of different, here's what I want to be called, which I think is really important. Here's what's important to me. Here's what I love. Here's all my photos. And I think that even the 5 minutes that it might take to really read that is hard. And my goal was, again, if there's one single 8x10 photo that's kind of striking right above the bed, you're kind of forced to see the patient. You're seeing the patient in the bed, but right above them is the snapshot of them as a human. And I think that I found that more striking than a busy board that you might have to take the time to read. But I think both have a lot of, I think they're both really important. I think you could have both in the room.
Thanks. Yeah, just curious.
I think it was similar to the photos that were on the walls in a lot of patients' rooms, but then our team would have our back to them, because some patients who are admitted for a while, their room is filled with personal touches, but when you're busy and running in and out, you just might not actually look around. So.
We're approaching the end, but thanks for the interesting talk. I think that's a cost-effective way to improve how people experience being in the hospital. I may have missed this, so I apologize, but are there other avenues of research using photography in medicine or mental health, or was this really motivated by your own insights and something interesting, or what triggered you to use photographs and thinking this would be an interesting thing to look at?
This is purely just because I liked photography, and I think patients will often bring in photos, and I always liked looking at them. And from whether it's in the hospital and patients would bring something in to see, or doing hospice visits as a fellow, I loved looking at patients' albums, and just I started asking patients to bring in photos, and I liked seeing them, and I started to think about how we could actually display them so that more people could actually benefit from seeing patients that way.
Have there been any?
There's in nursing homes, there's more literature looking at this. That a lot of nursing homes and facilities will put a picture on the wall or the door outside of the patient's room. That's been a HIPAA issue in the hospital, so it's not done as frequently. But above the bed, it's not a HIPAA issue. So more of the, I found that photographs are used more in facilities where there's different HIPAA, at least regulations, perhaps.
Great, thank you.
I had a quick question. One thing about your implementation of this as a resident, and did you? I think you mentioned something about like asking them one specific question about themselves. But like now, given what your work with photography, do you ever like? Would you recommend, or do you think it's feasible just as a resident to be like, hey, by the way, like I'm admitting you to the hospital. If you have any photos to bring in, you know, something like that. Because I think like looking back on my experience, even before medicine, the most meaningful ones were when I did get to see photographs of patients that I saw, or shadowed physicians and saw pictures of patients. And I just want to see how I can get that going for my patients easily.
I would just ask them, do you have any photos? And if you want, and we had a nursing, there's like a room with a color printer in the hospital that was like a lounge I was initially printing the photos at like a Walgreens, and they were costing me like $7 for an 8x10 print, and decided on a residency budget doing that alone. I wasn't going to keep doing that. So I just printed them on computer printer paper. I found a printer with color ink in the hospital that I could use for free. And I was having patients just email me the photo and printing them myself.
Wow, that's awesome.
But I think even just looking at the photo has power. But I think we have a color printer in our clinic, so I've used that. But now I've been having patients send it by eCare in the outpatient world, which actually will be really cool when we go to Epic in the hospital, because if patients are on eCare, they might be able to send you a message with the photo, and then you can just put it in your note too, or print it from there. I think that will make it easier. Rather, because then you have to otherwise give your email address out, which you might not want to.
Yeah.
But again, it doesn't take a lot of time and was kind of fun to do.
So Annie Weisner asked in chat, you get lots of thank yous, which is great. But they asked, if you have time, what pieces of advice did your patients offer for young doctors?
Oh gosh, I have hundreds of them. So I started asking that. My first month of intern year was on the inpatient service at Bellevue. And my only piece of feedback from the attending was not to spend so much time with my patients, which was impossible at Bellevue because everybody spoke a different language, and you'd have to come in at 6 a.m. to use a translator phone for every patient, and nobody would get discharged if you weren't doing everything yourself. So it didn't feel like the best advice. I reflected on it a lot and think about how I could have worked on time management, but I ended up going back and asking for the rest of the year. I asked all of my patients for a piece of advice, and I got a lot of really funny advice. I could give you all of them, Annie. I have them all typed up, but the thing that came up the most was just listening to your patients and really hearing them. That was probably the number one thing.
That. It would be so interesting. I'm sure there's some funny ones too.
There are some one told me to only buy fake bags from him on 57th and 5th. That was my
That's some New Yorker advice. Yep. Well, we're a bit over time. This is so wonderful. Thank you so much. And I'd like to note that this had one of the highest attendances that I can recall. So that's fantastic. And I saw a few people joining us from other departments. So thank you so much for doing all this and joining us